Good morning, we are from Group 6. We will be presenting our study on the hemiplegic gait cycle under subject KIB3018, Experimental and Computational Biomechanics. Our group members consist of me, Mia Hanan, Narisu, Rafiki, Arhana, Far Nushahida, Wang Yizu, and Zoin. This is our table of content, including our experimental results, discussions, and applications. Next, we will move on to introduction. Human locomotion is defined by the gait cycle divided into a 60% stance phase and a 40% swing phase. In a normal gait, these phases allow for fluid weight bearing and ground clearance. However, hemiplegia, which is a neurological condition typically resulting from unilateral brain damage, has caused significant asymmetry. Patients often exhibit foot drop due to weak dorsiflexors, leading to compensatory strategies like hip hiking or circumduction to prevent the tooth from dragging. Our study utilized the Vicon motion capture system and high-speed cameras to quantify these 3D kinematics alongside force plates to measure ground reaction forces. This objective data allow us to compare the stability and propulsion efficiency between normal and pathological walking pattern.
Moving on to the objectives. So we have to compare the gait profiles between the normal walking pattern and also the hemiplegic walking patterns. Next is to quantify the spatio-temporal. So this is to determine the differences in walking speed, cadence, and also step length. Next is assessing kinetic forces. So we integrate and implement using force plates to evaluate ground reaction forces distribution during weight-bearing phases. Next is map angle variations. So we include markers onto the subjects to identify 3D deviations in pelvic, heel, and toe kinematics. And lastly, to evaluate clinical stability. This is to analyze the biomechanical impact of cane usage and also compensatory strategies. Next is the apparatus and also materials. So to demonstrate the walking patterns of the normal and also hemiplegic, we use force plates. And also for the software, we use Vicon Nexus motion capture system. And for processing the data and results that we wanted, we use MATLAB. And for the subject, to demonstrate hemiplegic walking pattern, we use walking canes. And we put reflective markers onto the subject by using adhesive tapes.
Nextly, for the safety precaution, firstly, the subject must wear a tight-fitting black clothing and must be clear from other reflective surface. So this high color contrast ensure the shiny white silver marker are not overshadowed by the fabric and does not fit for the data to reflect actual anatomical motion rather than cloth displacements. Secondly, the marker must use a double-sided hypoallergenic tapes so that the markers remain securely in place throughout all the trials and preventing them from falling off during the movement. Thirdly, the cane must be placed on the opposite side of the injured leg. Fourthly, all measurement and trials must be conducted 3 times and mandatory rest between each trials to validate the accuracy of the results. And then fourthly, static calibration must be done for the experiment. And lastly, we must monitor the subject's foot. Placements must be inside the force plate and the subject's eyes must be leaning forwards so that to avoid unnatural gait of walking's error.
Hi, my name is Nariso. I will briefly introduce the experiment setup and data analysis. Our study includes 1 male subject, and the subject was required to walk through 2 force plates in 2 conditions with different gait: the normal gait and the simulated hemiplegia gait. The affected limb was set to the left leg and the cane was on the right side. Subject was required to walk in reciprocal gait when with a cane. The sampling rate of the motion capture system and the force plate was set to 100 Hz and 1000 Hz. Following the lab guide, motion capture markers were placed on the areas of pelvis, segment, joint, and feet. The experiment includes 3 trials for each gait, and the subject was asked to walk through the force plate with the left foot on the first plate and the right foot on the second plate to ensure the independent GRF capture. Hi, my name is Nariso. I will briefly introduce the experiment setup and data analysis. Our study includes 1 male subject, and the subject was required to walk through 2 force plates in 2 conditions with different gait: the normal gait and the simulated hemiplegia gait. The affected limb was set to the left leg and the cane was on the right side. Subject was required to walk in reciprocal gait when with a cane. The sampling rate of the motion data analysis include the time normalization of ground reaction force and the kinematics, as well as averaging of each matrix across 3 trials. All data processing and visualization were done in MATLAB. Accordingly, spatial temporal metrics were exported from the Nexus software, includes cadence, speed, stride step time, and length, percentage of support.
Normal walking demonstrates relatively consistent step length and stride length, with overall spatial symmetry and efficient forward progression. However, in the simulated hemiplegic condition, pronounced spatial asymmetry was observed. Step length was reduced on one limb, while the contralateral limb showed a compensatory increase, resulting in an uneven step pattern and higher variability. This increased variability suggested impaired interlimb coordination, which is typical of compensatory gait strategies. It showed a stable walking speed of about 1.04 meters per second, reflecting efficient coordination between temporal and spatial parameters. In contrast, similarly, hemiplegic gait velocity decreased steadily to 0.44 to 0.65 meters per second. This reduction was associated with prolonged step time, increased double support duration, and altered stand swing balance. Overall, the integrated spatial temporal results indicate that simulated hemiplegic gait is slower, more variable, and less efficient than normal walking.
I will continue with the ground reaction force analysis. This page illustrates the variation of medial lateral ground force reaction over the gain cycle, where the solid line represents the mean and the shaded band indicates standard deviation. Blue corresponds to the left leg and orange to the right leg. In normal gain, the medial lateral force at both legs shows an initial drop at the onset of stance, followed by the first peak during understand and another peak towards the end of stance. Variability among trials remain relatively small. Under the hemiplegic condition, only one peak occurred early to mid-stance, with reduced overall amplitude and borders as the bands. This pattern may indicate altered allocation and control of medial lateral force generation and stabilization throughout the gain cycle. For the anteroposterior direction, normal gain shows a negative braking segment in both legs during the early to mid stance, followed by a progressive raise toward mean positive peak by propulsion. The standard deviation band remains narrow. Under the hemiplegic condition, the magnitude of braking and propulsive forces are reduced overall, particularly for the affected limb, which has larger variability and later termination of the cycle. In normal gait, the vertical ground reaction force during stance displays a characteristic double peak pattern, with a rapid raise at heel strike followed by a high platform and a second higher peak at toe off in late stance. Interjaw variability remains small, producing narrow SD bands across the stance phase. In hemiplegic gait, the vertical ground reaction force during stance shows reduced magnitude at both heel strike and toe off peaks, along with a flatter stance platform and bolder SD bands. Variability is increased throughout the stance, and a part of the vertical load may be offloaded by a cane.
Lastly, let's take a look on the last experimental result, which are angle variation of the pelvic, heel, and toe. So starting with pelvic kinematics, we see a significant instability in the hemiplegic subject. So in the sagittal plane x-axis, the hemiplegic subject exhibits a much wider variance shown by the large red shaded area. So this indicates a pure control of anterior pelvic tilt. So moving to the frontal plane z-axis, we observe the characteristics of hip height deviation. The hemiplegic subject must lift the left side of the pelvic excessively to help the paralyzed limb clear the ground during a swing phase, a sharp contrast to the stable, flat trajectory of the normal gait. Next, the heel data reveals a total loss of the standard heel strike mechanism. In the sagittal plane x-axis, the normal subject shows a distinct peak as the heel strikes the ground, whereas the hemiplegic subject displays a flat foot or mid-foot landing. This lack of heel rocker makes weight acceptance very jarring. Furthermore, in the transverse plane y-axis, the hemiplegic heel shows irregular rotation, suggesting that the subject is struggling to maintain a straight line of progression due to the muscle spasticity. Finally, the two variations highlight the most dangerous aspect of hemiplegic gait, foot drop. In the sagittal plane x-axis, while the normal subject clearly dorsiflexes the toe to clear the ground, the hemiplegic subject's toe remain pointed downward during the swing phase. This creates a high risk of toe drag. This mechanical failure explains the pelvic hiking we saw earlier. The subject is forced to use their hips to lift their leg because the ankle and toe can no longer perform the necessary clearance movement. So that's all for the experimental results part. I will pass down for the discussion parts towards my friend.
Normal gait shows a highly ceramic and stable temporal pattern, with cadence close to 100 steps per minute and a consistent stride time of about 1.2 seconds, indicating well-coordinated neuromuscular control. In contrast, simulated hemiplegic gait exhibited marked temporal disruption. Pace decreased, stride time increased to nearly 4 seconds, and double support duration exceeded 50%, reflecting a shift towards a stability-oriented gait strategy. Normal gait demonstrated consistent step and stride length, suggesting efficient bilateral coordinator. However, simulated hemiplegic gait showed pronounced spatial asymmetry with reduced step length on one limb and a compensatory increase on the contralateral limb. Together with higher variability, this pattern indicates over-reliance on the non-affected limb to maintain forward progression. A walking speed of about 1.04 meters per second, reflecting efficient temporal spatial integration. In contrast, simulated hemiplegic gait speed decreased to 0.44 to 0.65 meters per second, accompanied by prolonged step time, increased double support and spatial symmetry. Although a walking can improve stability and reduce speed, suggest energetic efficiency was not fully restored, highlighting the need for rehabilitation, targeting propulsion and gait symmetry.
This section focuses on the analysis of ground reaction forces, or GRFs, which represent the interaction between the lower limbs and the ground during walking. GRFs are important for understanding gait stability, weight acceptance, and forward propulsion. In normal gait, these forces follow predictable and symmetrical patterns, whereas in hemiplegic gait, abnormal force patterns often occur due to neuromuscular impairments and compensatory strategies. For vertical ground reaction force, normal gait demonstrated the typical double peak pattern during the stance phase, corresponding to weight acceptance in push-up. The symmetry between the left and the right limbs indicates stable and efficient loading. However, in the stimulated hemiplegic gait, the affected limb showed a reduced vertical peak during early stance, suggesting decreased weight bearing. In contrast, the unaffected limb experienced higher loading, indicating compensation. The wider variability also reflects reduced stance stability. In terms of anterior-posterior ground reaction force, normal gait displayed a clear braking phase followed by a propulsive phase during terminal stance. In the hemiplegic condition, the propulsive force on the affected side was reduced, indicating weakened push-up due to impaired ankle plantar flexor function. As a result, forward progression relied more on the unaffected limb, and although the walking cane improved stability, it did not restore normal propulsion. Medial lateral ground reaction force analysis showed that normal gait had small and symmetrical forces reflecting good lateral balance control. In contrast, the hemiplegic gait exhibited increased medial lateral variability, particularly during single limb support, indicating compromised balance and greater reliance on compensatory strategies. Overall, these findings highlight asymmetrical force distribution, reduced propulsion, and impaired balance in hemiplegic gait, emphasizing the need for rehabilitation strategies that improve weight-bearing symmetry, propulsion, and medial lateral stability.
In hemiplegic gait, pelvic movement shows clear compensatory behavior.
In the sagittal plane, increased anteropelvic tail occur during loading response and mid-stand, indicating weak hip extensor. In the transverse plane, exaggerated pelvic rotation assists limb advancement, while in the frontal plane, increased pelvic obliquities or pelvic sagging is used to improve foot clearance, but this increases energy cost and reduces gait efficiency. Heel angle variation mainly reflect ankle control. Sagittal plane results show reduced dorsiflexion during swing and increased plantar flexions at initial contact, indicating foot drops. Transverse plane variabilities suggest unstable foot placement, while increased eversions in the plantar planes reflect medial lateral ankle instability, contribute to asymmetrical loadings and reduced stability. Tone kinematics highlight propulsion deficit. In sagittal plane, reduced tone plantar flexions during terminal stand indicate diminished push-off power. In transverse plane, increased external rotation during swing reflects circumductions to assist clearance. While greater frontal planes variability suggests impaired foot placement control, increasing fall risk and reinforcing gait asymmetry. Now, let's look at the comparisons of our findings with published hemiplegic gait kinematic study. First is from Watanabe and his colleagues. They analyzed the pelvic and lower limb kinematics across a gait cycle. Their results show increased anterior pelvic tail, exaggerated transverse rotations, and greater pelvic obliquities in pathological gait pattern. These strengths closely match our sagittal, transverse, and frontal pelvic angle variation, confirming that the pelvic compensations observed in our hemiplegic gait are consistent with published clinical kinematics profile. Next study is from Balaban and Todd. They reported abnormal pelvic rotation pattern, particularly excessive pelvic retraction during swing in hemiplegic gait, as shown in the figure attached here. This aligns with the increased transverse pelvic rotation observed in our result, supporting the interpretations that pelvic rotation is used as a compensatory strategy to assist limb advancements when distal joint mobility is limited. Last studies is from Buderans and his colleague. They presented sagittal plane joint angle waveforms, as shown in figure attached here. It's showing persistent ankle plantar flexion during swing and reduced push-off in hemiplegic gait. This finding closely corresponds with our heels and torn sagittal result, where there is the presence of foot drops and diminished proportions in our simulated hemiplegic gait.
Next is application and rehabilitation. The first point is restoring efficient propulsion versus stability. Now, the demonstrated hemiplegic trials, it shows that increasing double support time to 54%. Now, it shows that the subject kept both feet on the ground for a longer time to avoid falling. Even though walking cane is there to support him, but it didn't help the leg to push off the ground, creating failure to restore active propulsive process. And the goal for rehabilitation is that to prioritize strengthening ankle plantar flexors to recover push-off power. Next is managing pathological compensations. Now, compensations include pelvic hiking, circumduction, and exaggerated transverse pelvic rotation. Now, this is to help toe clearance. What does this do is that it takes a lot of energy and can cause bad back pain over time. So we are trying to avoid this kind of issues. So the solution is that we can propose use a special brace and AFO early on and keep the foot in a good position so the patient doesn't have to learn these bad hip habits. Next is data-driven personalized rehabilitation. Now, the data that we could get from the Vicon motion system software, it provides precise metrics for joint angles and loading patterns that visual observation cannot detect. So it can help in case of rehabilitation. This can avoid this kind of issues. Next is quantitative data allows evaluation of a specific assistive device in improving stability. Now, in case of we have to check if the assistive device is helping or is just a temporary fix. So from this data, it can prove it is helping the patient. And lastly, it enable healthcare professionals to track recovery milestones accurately. So it can adjust to what kind of patient they are seeing and how they will implement the training for this type of patient.
Next, we move on to limitations. Our analysis identified two critical technical limitations. First, the use of healthy subjects to simulate hemiplegia lacks by fidelity. True hemiplegic gait is governed by complex neuromuscular impairments and spasticity that a healthy individual cannot authentically replicate. Healthy subjects may subconsciously maintain more symmetrical loading patterns or higher joint stiffness, which skews the kinematic data away from true pathological behavior. Second, we encountered significant motion artifacts because reflective markers were placed on standard clothing rather than the skin. The fabric moved independently of the underlying skeletal structure during the walking cycle. So these relative displacements introduce noise into the joint angle calculations and also potentially leading to inaccuracies in tracking the exact degrees of knee flexion and pelvic tick. To enhance data reliability, we propose three primary improvements. Ideally, recruiting actual hemiplegic patients would provide the most authentic representation of gait symmetry and ground reaction forces distribution. If patient recruitment is restricted, we recommend the implementation of ankle foot orthosis (AFOs) during simulation. By mechanically restricting ankle dorsiflexion, an AFO forces the subject to adopt authentic compensatory movements like hip hiking and reduce propulsion on the affected side, producing a gait profile much closer to true hemiplegia. Finally, to eliminate motion artifacts, we must standardize the use of tight-fitting compression wear or direct-to-skin marker placement. This ensures that the Vicon system tracks anatomical landmarks precisely, minimizing displacement errors and ensuring the integrity of our computational biomechanical model.
In conclusion, hemiplegic gait show reduced efficiency, increased asymmetrics, and relies on compensatory strategy. Slower walking speeds and reduced propulsion reflect angle weakness, although a cane might improve stability, but it does not restore push-off. Overall, the findings is aligned with published studies and highlight the importance of improving ankle functions and pelvic stabilities in rehabilitations. That's all from us. Thank you for listening.